integration and strengthening at service delivery level. Mrs. Farrell's recent work has focused on developing a system approach for integrating family planning within HIV care and treatment services, an approach that is applicable for family planning integration with other ARH services, including strengthening family planning within maternal services. Mrs. Farrell was actively involved in the Postabortion Care Consortium, as well as providing support to activities led by USAID in developing the PAC Global Resource Package I'm sure you all know. For your information, this webinar is being recorded. It will be made available on the PAC Consortium website by the end of this week. If you have questions or comments, they can be typed. You can type them out into the chat box on the Go to the Webinar panel. There will be time to ask questions, and we will check those questions, and Betty will be able to respond to the questions. So Betty, the floor is yours. Thank you again.
Thank you, Boniface, and thank you everyone for joining us today. Our program is going to focus on post-abortion care and using a service integration approach within post-abortion care to strengthen family planning. We're actually going to have 3 objectives for the webinar. We're going to discuss the EngenderHealth service integration approach, its background, definition, and the principles involved. We'll discuss the family planning levels of integration and the 5-step integration approach. And then we'll explore the application of that approach in strengthening family planning and post-abortion care. Post-abortion family planning is an essential element of post-abortion care. Approximately 210 million women become pregnant annually, with 40% of those pregnancies unintended. 31 million will experience a spontaneous abortion. 44 million will induce an abortion, with half of those through unsafe means. And 47,000 women will die from unsafe abortion, contributing to 13% of maternal deaths. With the early return of fertility following a first trimester abortion, family planning should be provided immediately after treatment. Post-abortion family planning prevents subsequent unintended pregnancies, repeat abortions, and reduces risks of adverse maternal outcomes in pregnancies following spontaneous or induced abortion. Regardless of the method of uterine evacuation, be it medical or surgical, FP, family planning, is considered an integral and essential part of the package of care. And you can see that in the slide with the list of elements of post-abortion care. While these benefits can be realized by increasing women and couples' access to contraceptives immediately post-abortion, many women are not offered family planning immediately after treatment. Post-abortion family planning offers an additional benefit of cost savings to the provision of service as well as staff utilization. But in many settings, parallel administrative lines do not coordinate with related services, such as family planning usually sits under preventive services and treatment for incomplete abortion under curative services. So, how do we ensure that provision of treatment functionally includes family planning, the preventive element? Well, let's look. In 2005, EngenderHealth formulated a systems approach for integrating one service with another, specifically for family planning with HIV care and treatment. Following implementation and evaluation, this generic approach was used to not only integrate family planning with other services, but to strengthen family planning within areas of maternal health where family planning was underutilized. And this can be seen often in immediate postpartum family planning that is offered with labor and delivery services. Now, let's talk about service integration. What does it mean? While there are several definitions of service integration, our working definition is the following. It is an approach in which health care providers use opportunities to engage the client in addressing broader health and social needs beyond those prompting the initial healthcare encounter. By this definition, we focus on the client, and in so doing, it requires engagement of related health service leadership, the staff, service users to assess, plan, implement, and monitor a process of integrating or strengthening the family planning unit of service consistent with the unit or site's capacity to achieve and sustain it. Based on the experiences implementing this approach, we saw 5 key principles emerge. To support a site to successfully integrate, we need to provide comprehensive services that are relevant to the client's desires, needs, or risks. We need also to integrate to the capacity of the core service. The aim is to enhance the service, not to stress the health services. Then, support service delivery modification, system strengthening, and reorganization of work, of space, and staff functions. Don't forget, there are demand and awareness creation activities as well as enabling environment activities that need to be part of the planning. And lastly, explore the role of community and men in prevention and health promoting behavior. They are important partners and we need to engage them. So these principles are key guides to working towards successful service provision and use. So let's move on to levels of family planning integration. If you look at the chart, in this slide you have 5 levels of integration, and they reflect a generic breakdown of the various levels of integration by provision of specific family planning methods. The site or unit assessment findings, when analyzed, can help site staff determine what might be feasible for implementation. So if we look at the chart, we'll see that in level A, it provides the foundation functions of information provision about family planning, assessment of risk or needs, counseling on the available family planning methods that are in country, their role in protecting against STIs and HIV. This level, level A, provides condoms and instructions for use, and in some settings they may also provide emergency contraceptive pills. They will refer for other methods that they don't offer on site. Level B builds on the activities and functions of level A and offers pills, counseling for their successful use, and the management of side effects or complications. Level C builds on the functions of level B. Level C builds on the functions of level B and offers injectables, again with instructions for use and management of side effects and complications. Level D builds on level C, providing methods such as IUD and implants, instructions for successful use, and management of side effects. Level D very often also accepts referral from other lower level sites. Lastly, level E provides all of the functions of level D plus surgical methods and instructions for self-care and follow-up. When we look at these, it gives the site an opportunity to determine possibly what they can provide given their structure. Once the capacity and level are determined, the family planning strengthened element of post-abortion care in practice might be categorized and look like this. And you will see that you should have a link in your boxes that will open up a chart. This chart looks at basic, intermediate, and comprehensive categories of service delivery. At a basic category of service delivery, you will see there may be skilled providers and counselors, but they may not always be available. And sometimes this happens because there's not enough staff to cover late evenings, to cover weekends, discharges. The providers may have been deployed elsewhere. They may not have been trained in family planning, or they may not be scheduled or just absent. So the services that basic category of service offers is limited. At an intermediate category of service, there may be limited infrastructure for providing more than condoms, pills, and possibly standard days method, and or there are limited numbers of family planning skilled staff. But where there is infrastructure and adequate number of trained staff to provide counseling and an expanded range of methods and services, this would be considered the comprehensive category of service. Now, before we go into the actual functions of these three categories, let me just share a note about the timing of family planning post-abortion. Most methods of contraception, including the IUD in the absence of infection, may be initiated immediately post-surgical treatment of incomplete abortion. With the exception of IUD, hormonal contraceptives may be initiated at the time of medical management of incomplete abortion. So just to give a sense of the facility with which family planning methods can be provided at the time of treatment. So let's look at the scope of services under each of these categories that I listed. And you'll see in the chart that we have a big box overarching that says all levels of post-abortion service before discharge should include the following: assess the client's risk for subsequent unintended pregnancy or desired pregnancy, counsel the client about the risk of pregnancy as early as 1 week following emergency treatment, counsel the client about the benefits of waiting 6 months before trying to conceive for optimal birth outcomes. This is referred to as healthy timing and spacing of pregnancy. And then provide the client with brochures for post-abortion self-care and family planning. Now the chart is broken up into two because we have two audiences. We have clients who may desire a pregnancy and clients who may want to prevent a pregnancy. For the clients desiring a pregnancy, if you would like to support them at a basic level, our task is to refer the client to family planning clinic within 1 week of discharge and provide before discharge condoms and emergency contraceptive pills if they're available, with instructions for use. Include messages on healthy timing and spacing of pregnancy to achieve optimal birth outcomes, and provide a referral for 6 months to introduce standard days method to help achieve a desired pregnancy when the couple or the client is ready. Counsel the client about dual protection and refer to a relevant clinic for STI and HIV assessment, including information about location and hours. For the client, for the client who desires a pregnancy at an intermediate site, they will provide all the basic functions just mentioned and include counseling the client about family planning methods characterized immediately by immediate return of fertility when it's discontinued. They would also provide the client's chosen method before discharge, be it condoms, emergency contraceptive pills, standard days method, pills, or injectable hormones, depending on the type it is, with instructions for use. And lastly, refer to the family planning clinic within 1 week of discharge for desired reversible method if those are not available on site. Include location, hours, and contact information of the referral site. And then at the comprehensive category of service, all of the previously listed functions would be carried out, plus the provision of STI and HIV assessment and management, then the provision of standard-based method to help the client or couple achieve a desired pregnancy. For the client who is wanting to prevent a pregnancy, under the basic category of service, they would refer the client to family planning clinic within 1 week and provide before discharge condoms and emergency contraceptive pills if they're available with instructions for use. Counsel the client about dual protection and refer to a relevant clinic for STI and HIV assessment, including location, hours, and contact information of referral site. At the intermediate category of service, all of the basic service functions would be offered, plus counseling the client about the range of family planning methods depending on her reproductive intentions. For example, short-acting methods for spacing, or long-acting and permanent methods for longer spacing and limiting, respectively. Also provide the client her chosen method before discharge, be it condoms, ECP, standard days method, pills, injectable hormones, implants, or IUD, with instructions for use. And then refer to a family planning clinic for permanent methods or preferred method if it's not available on site. And then the comprehensive level would build on all the functions in the intermediate level, category of service, plus provide permanent methods with instructions for use and self-care before discharge, and provide standard STI and HIV assessment and management. At follow-up visits for post-abortion care clients post-treatment, the focus should be on assessing recuperation, assessing the risk of STIs and HIV, counseling for risk reduction, practices, and referral to counseling and testing services as indicated. If a method was initiated at discharge, assess for correct use, satisfaction with the method, and management of identified side effects, if any, or method change. It is important to note that if counseling and testing is indicated for the client or couple, emphasize the importance of knowing their status to better plan for a desired pregnancy while minimizing the risk of HIV transmission should the test results be positive for one or both individuals. So at this time, I can take a couple of questions if there are clarifications that are needed before moving on. Okay, so let's move on, and we'll look now at the steps, the actual steps then, of the service integration approach. What you'll see on the slide is a 5-step process, and we'll go through each of the steps, and I will highlight some of the key activities that happens under each step. Step 1 basically is engagement. It is identifying or refining the level of family planning strengthening that can be achieved by the site. And this involves several activities of engagement. One would need to identify key stakeholders to maximize collaboration and cooperation and promote ownership. And this is especially important when you want to bring together curative and preventive decision-making personnel. Select a mutually agreeable time for a half-day session stakeholder meeting covering benefits of post-abortion family planning, introducing or refreshing the international standards of care and update on post-abortion family planning recommended practices, international standards of care and updates on post-abortion care practices, and exploring perceptions of current quality of care in post-abortion care service delivery. Share important post-abortion family planning policies and or make plans to review and update those policies if they are dated. Also, formulate or activate a post-abortion care working group to advise, guide, and monitor post-abortion family planning strengthening and advocate for support to the sites and promote post-abortion care policy review if indicated. The activities in step 1 are key to getting as much support as possible to make service delivery changes. In step 2, we look at assessing the site's capacity to provide family planning strengthened post-abortion care services. If the site is not consistently providing post-abortion family planning or providing a limited range of methods, we wanted to carry out a set of assessment activities. Form a team with selected stakeholders to conduct the assessment, looking at underlying causes for inconsistent or limited family planning method provision. It's critical to look at the physical structure. How will the space be used? A designated post-abortion care service area? Is that space private, honoring auditory and visual privacy? Are commodities in the area of uterine evacuation, such as IUD instruments and supplies for insertion? What is the staffing in relation to workload and client volume patterns? And service delivery system capacity to expand or strengthen family planning. What is in place, and are there weaknesses that need to be strengthened? Also in this assessment, map family planning referral sites that would be easily available for clients, and that would include internal as well as external referral sites. Following the assessment, the team compiles and analyzes the data and findings to determine the feasible level of family planning to provide immediately post-abortion. Then, organize and hold a follow-up stakeholders meeting to share findings, tailor an action plan, and this would involve the upcoming steps 3 and 4 activities, and gain necessary senior and management level support. The idea in step 2 is to ensure that we plan for success. In step 3, system strengthening to operationalize the family planning element of post-abortion care activities will build on the assessment findings from step 2 and are used to tailor interventions. The most commonly affected service delivery systems would be the ones you see listed under step 3. If we look at supervision, what could we do there to strengthen them, to support post-abortion family planning and new practices? We would need to orient or train supervisors in post-abortion family planning methods, practices, and service management requirements so that they can effectively provide coaching and support of quality service delivery. Refresh supervisor skills in supportive or facilitated supervision with a focus on post-abortion family planning. And engage supervisors in updating supervisory tools to reflect the post-abortion family planning element. In the area of training, based on the level of post-abortion family planning that the site will be able to offer or aims to offer, staff providing methods will need to be trained. Competency-based training will be required for all methods, with particular emphasis on simulated practice of skills and practicum for IUD and implants. Determine the most time and cost-efficient method of training for your setting and assess client volume to support training, such as group-based training or structured on-the-job training. Then develop a training plan and budget that will cover the overall training needs for strengthening the family planning element of post-abortion care on site and among referral staff. For the commodity logistics, because we definitely need to have support in the supplies and equipment to provide the family planning methods post-abortion treatment, We will need to orient staff responsible for maintaining stock and inventory to the required equipment, instruments, supplies, consistent with the level of post-abortion family planning that the site or unit will provide. Include client materials and job aids on the requisitions. And ensure that stock and inventory personnel use the commodity logistics system in a timely manner to avoid stockouts. For the referral system, it is important we should note that unless it is the woman's choice, access to family planning, counseling, and method provision should not be deferred to a follow-up visit. And in order to make the referral system work more efficiently, we could develop and revitalize referral slips for both internal and external referral. Maintain an updated roster of conveniently located referral sites for women needing referral, be it internal or external, for their preferred method. And the mapping, as I mentioned before, would be part of Step 2, assessment activity. Then maintain a supply of condoms and emergency contraceptive pills to offer women who may not be ready to accept contraceptive method at discharge or who may desire a method that's not available on staff. This way, clients can have what they need, even if you have to refer them elsewhere. In the system of record keeping, HMIS forms that do not reflect post-abortion family planning can be supplemented by using the standardized family planning service form. And maintain the post-abortion cure service records that indicate family planning counseling, method selection, method provision, and referrals. Last but not least, in the area of policy, work with regional or district health leaders to ensure that administrative policies and procedures, service guidelines, expanded job descriptions, and systems modification directives enable service managers, supervisors, and providers, both facility and community-based, to offer family planning as an integral element of post-abortion care. Engage the PAC working group to advocate for needed policy support. Moving on to Step 4, we identify resources to support family planning strengthened post-abortion services. Resource persons and groups identified during Steps 2 and 3 may be useful in creating awareness of the strengthened services, in sharing accurate information about post-abortion care and family planning methods, the need for timely treatment of bleeding in early pregnancy, and making referrals to facilities when women have symptoms needing assessment and management. These resources can be vital in stigma reduction interventions. Referral site staff are also key resources to ensuring that women and couples receive their preferred method with minimal barriers. So for these resource persons and groups to carry out the listed tasks above, it may be necessary to conduct formal or informal learning sessions on symptoms indicated in referral, available family planning and methods and their use, and how to dispel misinformation about family planning. Invest in referral site staff to ensure consistency of family planning, counseling, and method provision, and if training is required, include their training in the training plan and budget. Explore with resource groups and potential champions how best they may become involved in stigma reduction activities. And then we move to Step 5. Step 5, we phase in and initiate the family planning methods that are going to be part of post-abortion care. We monitor service quality and determine the feasibility and timing for method expansion if it's needed. So, under Step 5, continue offering family planning or expanded method options within post-abortion care service and coordinate awareness creation activities to inform communities in the surrounding areas about these services. Monitor progress and service quality along the way with whatever ongoing quality monitoring mechanism is in place, including clients and monitoring activities. Clients are very valuable in giving you realistic feedback about what is working and what is not. Based on quality monitoring, determine the need to strengthen service areas that may need additional support or to expand the family planning method mix if that's indicated. And those are the 5 steps and highlights of the activities under those 5 steps. So I can stop here and take questions for clarification if necessary.
Okay, Betty, this is Boniface. I have one question. It's just relative to step 2. You mentioned that during the assessment, we need to make sure that there is a designated park services space area. And we've been struggling in several countries. Could you refresh to people why we need a space, a special space, designated space for post-abortion care, and how has been your experience in the countries where EngenderHealth has been working in getting this space? Some where really they take care for post-abortion care.
Yeah, for the post-abortion care client, whether it's induced or spontaneous, they have special needs, and it is ideal if it can be a space where the procedure can be carried out, where they're not in close proximity to women who are having babies or nurseries, things like that, because it is an emotional time, regardless of how the pregnancy loss has occurred. And so what we want to do is provide an environment that is facilitative and supportive of the woman and her needs. So a separate space is ideal. Some places have actually looked at their setting, found rooms that have been not used efficiently, have been storage rooms, and they've been able to set them up either as procedure rooms, depending on how close they are to running water, etc., and use those as space not only for procedure or for recovery. So that's the other issue, is your designated space needs to not only address the procedure but also address recovery space. Ideally, a separate room that can minimize noise. It may not always be possible, but at least efforts should be. Means that it's critical for the step 1 engagement to have support from senior level to make it possible to either make sure that they stand behind the site's attempt to create a space for post-abortion care, and if there are opportunities for resources in the community in step 4 to contribute to helping make that happen, they can also be a resource. But the idea is to really protect privacy for the client presenting for post-abortion care. Does that answer your question?
Absolutely. And one thing I want to add is also having some of these clients who are young people who don't want to see their adults in the maternity room and so on. Yeah, absolutely. And your experience now with the countries where you were able to get space or not?
Yes, in places that have had challenges for space, unfortunately they've had to do the best they can with using screens to separate the procedure space, or unfortunately they've had to share space with the delivery room, and it winds up being first come, first serve. And then recovery, if they can be recovered, I've seen places where they've actually recovered the women for a short period of time and transferred them to a GYN unit, or they recover them and discharge them as quickly as possible.
I
Okay,
wanted to
Betty,
remind to everybody that you have a possibility to write down your questions in the chat to go to the webinar panel. Yeah, thank
Yep,
you.
and so we have one other question,
Okay.
Betty. It says, we found in some projects that stigma is a big problem in terms of
Mhm.
recording services because
Mhm.
providers do not want to record post-abortion family planning as post-abortion family planning. They just want to record it as family planning
Mhm.
to avoid having any record of the abortion. Is this something that you've seen, and how can you address it?
Oh, challenge. It's not something I have seen personally recently. However, what I do realize is that so much of the quality of work and the reduction of stigma has to do with the type of training that the providers have, the engagement of communities, and working with communities and champions who are willing to work with communities to help minimize the stigma will make a difference. Um, the, the, the work has to help providers become comfortable with the fact that the work they're doing is saving lives. And if we
Uh-oh.
they record statistics, the better able we are to strategize how to improve services and how to minimize the risk that women often put themselves in when they either terminate a pregnancy, an unintended pregnancy, or when they have a spontaneous abortion and people assume it's an induced abortion and create barriers for them to get the services they need. I think a lot of it has to do with the investment in the type of training that deals with attitudes and attitude shifting and working with in partnership with community resources.
Great. Okay, we just got a couple other questions come in. I think we
Okay.
can take these two, and then we'll move on and have time at the end for more questions.
Okay.
So this one says, when focusing so deliberately on immediate family planning provision, particularly in a stigmatized social context that can lead to coercive or punitive family planning provision, how can we make sure that providers maintain a client-centered focus and uphold informed choice?
Yeah. And here again, I believe that's why I started with investments in supervisors. The supervisors or whoever is in charge in that unit really has to be committed. They really have to be a champion to quality care, which means that in stigmatized settings, they have to be brave enough and willing enough to demand of their staff that this is the standard of care and we are going to carry it out. And sadly, in many settings, senior level may not necessarily give them the type of backing they need to be able to enforce or ensure that the staff will provide practice to standard. But I believe if we can, to the degree possible, in step one, engage partners, even those who may be on the fence or opposed, if we can engage them in a way and help them realize that this is life-saving, that they need to really get behind and support the supervisors for quality of care. If they're interested in saving lives and reducing maternal mortality, this is one of the areas that they have to weigh in and invest in.
Okay, and then the next question, which I think actually leads us very well into the next section that you're going to talk about, is can you share any lessons about convincing governments to integrate PAC as you have recommended? Do you have health or cost data that might help in this advocacy effort?
Well, I'll answer the last part first. I don't personally have at my fingertips cost data. I am not able to provide that in this session, but I certainly would be willing to work with the Post-Abortion Care Consortium partners to see if we could generate that data and put together something for sharing. As far as convincing ministries of health or NGOs that offer service to integrate post-abortion care into maternal health service, this definitely is one of the big strategic endeavors that can be influenced by external forces, working in partnership with allies in countries. So if there are influential donors, influential influential individuals in the health community who can find allies within the country and strategize how to bring around, and if they can't bring around those who are in opposition, at least figure out a way that those who are in opposition may not necessarily be able to block the progress of offering post-abortion care as part of maternal health services. I think we would remember that in the beginning of HIV, there was a lot of resistance to, in faith-based communities, in some faith-based communities, to offer condoms for protection. And with strategic initiatives in trying to collaborate, we saw a change in even some of the Catholic institutions where family planning not family planning, but condoms were used and allowed to be offered as a protection against HIV. So I think we do have the possibility to form strategic alliances and develop approaches to problem solving the resistance. I hope that answers the question. Okay, so I think we should move on. Here's a country example I'd like to share, and it comes to us from Ethiopia. In Ethiopia, in 2009, EngenderHealth's ABRI project team began preparations to pilot family planning integration across the maternal child health services and as well as HIV services. And this included comprehensive abortion care and family planning strengthening in PAC services at 40 sites. The initiative ran for 5 years through 2014, and we should note that the government of Ethiopia policies support service integration, and abortion services are legally available. So, the ABRI team followed the 5-step service integration approach, as you can see in this slide, and they applied it across maternal child health services as well as HIV. But we're going to look at the progress that they were able to make in not only comprehensive abortion care, but in post-abortion care services. So under this approach, a number of activities were carried out by them. In step 1, they were able to achieve buy-in at all levels. Through their activities in step 2, they carried out a rapid assessment. It was undertaken in each of the sites to identify existing opportunities and gaps for service integration. They also developed plans of action that were specific to the units to achieve the desired family planning service integration level they could achieve and sustain. So those were results of those were their step 2 activities. Family planning integration orientation was provided to staff from the focus service units, and this was their step 3. Family planning skills training was carried out by structured on-the-job training and group-based training for on-site and referral staff. So this included activities under step 3 and 4. Additionally, under step 3, they were able to facilitate the availability of family planning commodities. They also provided counseling guides and job aids, and they initiated or revitalized the use of referral slips. All clients served in the intervention units were offered family planning counseling. Clients interested in adopting a method either received it in the unit or through internal referral, depending on the method of choice and the service integration level of that unit. And that was their step 5. And then periodic service monitoring, supervision, and coaching were conducted jointly within the ABRI team and with the on or off-site supervisors. So that was their step 5. The Aubrey project's primary objective was to improve access to comprehensive abortion care and family planning, addressing issues related to supply, enabling environment, and demand. And the 5-step process resulted in an increase of family planning uptake. So if we look at this chart, what we can see is that in this beginning, only 33% of clients were actually receiving family planning post-abortion. But by the end of their 5-year period, 84% were using or selecting family planning method post-abortion. And if you look at the second chart next to it, you will see that in most places, injectable hormone is the most popular method. With the investment in strengthening the sites to provide a wider range of family planning methods post-abortion, IUD and implants were significantly increased in comparison to what you usually see as a profile for method selection. As a result of these achievements actually resulted because there was an inclusion of overview sessions on family planning in all trainings for comprehensive abortion care providers. And the training of comprehensive abortion care providers included long-acting and reversible methods, as well as identification of selected providers to offer permanent methods. The efforts included fostering a culture of internal referral and supporting post-abortion family planning during supervision visits. Lastly, monitoring to improve service quality, continuity, and widen the method mix was an ongoing process. So with a combination of these 5 focused activities, we see that it did make a difference in the uptake. So let's take another look at the results of the approach over the course of 5 years. And in this slide, what you can see is that as time passed, the number of abortion clients selecting family planning and the post-abortion care clients selecting family planning significantly increased. You see the number of family planning adopters for all methods in the medium blue color. And in the lightest blue color, you see the number of those who adopted the long-acting and permanent methods. So there was a significant increase over time. And on the slide, the chart next to that one, you can see the difference in, or the breakout of the percentage of family planning adopters post-abortion or post-abortion care. And of those, you can see the percentage of adopters for long-acting and permanent methods. So it does speak to making a difference for increasing access to the wide range of methods that women or couples would like to use, particularly after loss of a pregnancy or termination of a pregnancy. Okay. I would have to say that the Aubrey team summarizes the experience quite well and accurately by saying that when they used the service integration approach, it provided ingredients for success. It increased access and use of family planning following services for abortion or management of incomplete abortion. Service sites were able to tailor the level of integration to meet their specific context. Support from healthcare leadership or early engagement of facility managers and providers facilitated planning and implementation. Regular or periodic monitoring and technical assistance aided in problem solving and institutionalizing expanded services. And the process of this 5-step process can be adjusted and repeated to expand method mix consistent with a site or unit's capacity. So it lends itself to supporting service delivery changes. So in closing, I would like to close with a reminder and with a quote. The reminder: regardless of the method of uterine evacuation, medical or surgical, family planning is an integral and essential part of the package of care. And the quote: if the woman we treat for post-abortion complications is here because she cannot or could not get contraception, we have failed her. If she leaves without family planning, we have failed her twice. So we offer this approach, and we offer this approach to help us work more efficiently to support women's access to the services they need. So I thank you for listening, and I am open to taking questions for any of the content that we covered so far. Thank you very much.
Thank you so much, Betty.
You're welcome.
Okay, so we do have a couple of questions. So one of them was just looking back at the Ethiopia data, wondering why were so many more people seeking abortions during that time. I think we saw the we can go back and we can see that chart. So I think it's questioning why the number of clients for abortion and post-abortion care is going up so much.
You have to remember that this is a country that had recently passed legislation to make safe abortion services legal. So, of course, these services are beginning, and when the services are beginning and people are becoming aware that they are available, then they present for service. I don't know if that's answering your question.
Okay. And then the next question, and this is the last one I have, but people please feel free to continue typing into the chat box, is about post-abortion care working groups in countries. And if you can talk about some examples of that, or maybe some countries where they have set that up and it's been functional.
Right. So, for example, again, in Ethiopia, where you have a concerted effort and partnership with Ministry of Health and with donors and with health staff in the various geographic areas of the country, there is an opportunity to identify people who would be advocates and resource persons to help move the post-abortion care service delivery forward. This is why one of the first steps is to actually create a space for everybody to get as current and updated information as possible about post-abortion care and post-abortion care recommended practices. When those working groups are formed, usually it's someone at the senior level who actually endorses the formation of the working group, and that can be initiated in conversation with whoever is taking the impetus to spearhead the post-abortion care service delivery. The post-abortion care working group then is a partner. It's almost like a public-private partner that helps ensure that all that is necessary to make services work is accounted for, such as policy. Are the policies up to date? If they're up to date, are they out to the service sites? If they're out to the service sites, do the providers know about it? Do the supervisors know about it? Are the communities aware? So there are many. That's one of the roles that the post-abortion care working group can offer. They can also be a resource in reviewing documents. They can be a resource in advocating for support of supervisors to be able to be skilled and supportive in coaching for quality service delivery. One of the things that does raise its head is if there is a working group, who pays for the folks to come together periodically? And this is something that has to be determined internally. Because people may have to travel, to attend the groups, or it just may be part of how business is done. But it is something that whatever barriers would be present to supporting a working group to really be a resource for post-abortion care and post-abortion family planning needs to be addressed and strategized for problem solving.
Mm-hmm. Betty, this is Boniface.
Yeah.
Arbery was a project, right? Was
Yes.
support.
Mm-hmm. Mm-hmm.
It ended in 2014.
Mm-hmm.
Do you know what's going on now? Could you tell us what's going on now?
They're
activity.
Activity.
They're still active, and how they are supported, and so on. Yes.
Yes.
This is linked to the previous question, the one they asked you. Yeah.
Okay, there was a project that was supported by the anonymous donor, and at the end of this, it was also a partnership with the Ministry of Health, so that there was the okay by the Ministry of Health and support to keep this going. At this point, now that the project is ending, I know that the site and the team is still active. And I cannot say, I don't know personally yet, whether there is a follow-on. And there may be somebody in the audience who's working more intimately with the Ethiopia project at this moment who might be able to respond.
Yeah, Betty, I was just going to say, I think we have one of our colleagues, Jamal from Ethiopia, who is here. And Jamal, I know that the internet connection can sometimes be a little dodgy, but I'm going to unmute you, Jamal, and I think you also had a comment that you wanted to make regarding the legality of abortion. So, Jamal, you can go ahead.
Good.
Okay. Hi, everyone.
Hi, Jamal.
Hi.
Thank you for joining.
Hi, Betty. Thank you very much. Just to reflect on the question one of our colleagues raised, the project is still actively ongoing. So, like, we have continued to provide our support, but we also continue to expand the service to additional new sites. Almost we have expanded to additional around 177 more sites than what Betty has reported. So all in all, we are now supporting nearly 420 facilities over the last 6-7 years. And in terms of the caseload, why it is increasing, and one of the reasons is because we keep on expanding the number of sites, but still even within a given site, as Betty mentioned, when people start to know that such types of services are available and allowed, they continue, like, they can freely come to the health facilities, and when they happen to have also good provider who are like well informed, who have relatively good attitude towards such clients, so clients have a confidence to come and claim the services. So that is also another reason for us to see the number of abortion care clients keeping increasing from time to time. Did I address your question?
Absolutely.
Thank you so much for weighing in, Jamal.
No problem. And then maybe to just made some minor correction. Betty has mentioned that like abortion care is legal in Ethiopia. Yes, it is legal, but like safe abortion care is not 100% or totally legal under the legislation. Like there are conditions under which the government has allowed, and it will not be like legally punishable to exercise. Otherwise, still our penal code puts abortion as illegal, but there are around 5 conditions which like can be which anyone which needs which requires abortion care can sort of claim and like make a reason to claim the service. So that's why we say it by proxy. It is almost liberal, but in terms of the law, it's not like allowed. But the 5 conditions And the law also asks the providers to provide the service as per the words of the women. So no provider is like have a right to question, like for example, if a woman says she's raped, he has to take her or she has to take her word and provide the service, and they have no mandate to question beyond that. So that is what it makes it more liberal in the way Betty mentioned. Otherwise, legally it is not yet 100% legal to give safe abortion care service for any reason.
Thank you for the clarification, Jamal.
You're welcome.
And Jamal, we actually just got a question regarding those 5 conditions, and the question is whether are those written into the penal code or is it a medical ethics code?
They are in the penal code at the same time, but there is also a technical technical guideline the ministry like developed to put into effect the penal code. So it is more elaborated in that technical guideline for abortion care service provision in Ethiopia. So both the conditions and the types of providers, standard care and everything is like very much detailed out there.
Great.
Okay. Thanks. And then we got one other question about, and I think this is an interesting question about data collection. And Betty, hopefully you'll be able to address it. Is for the post-abortion family planning numbers, do those include only women who accept a method before leaving the facility after post-abortion care? And if not, how long after receiving PAC do you count them as accepting post-abortion family planning?
If Jamal is still on, I think he's the better person to answer that question.
Jamal, did you hear the question?
Good. Yes. Yeah, actually, we depend on, like in our data collection for the report, we depend on the because we support entirely government health facilities. We depend on the government HMIS system, so we get the report from the actual records of the health facilities. In terms of how we count the post-abortion family planning, for some of them, it all depends on the types of comprehensive abortion care services. So some of them, if they take, like, for example, MVA, they might take it right away, and if they are not like infected, of course. So that is immediate. And for the rest, for example, some of them for safe abortion, they may take medication abortion, so they have to come for after 48 hours as per the procedure, and then they have to claim the misoprostol. And after that, they took the method if it's not a hormonal method. So, but like we don't count those who came late after this time to claim for a family planning method. So these are more or less the immediate and then immediate post-abortion family planning uptake, while the client is at the facility either for the complete care or for a follow-up care.
Okay.
Yeah. I want to add it to a situation where sometimes the clients would say they want to consult to their husband, and they will come back and they go to the family planning unit. We need to have a system to track those who come and they go to the family planning unit, so that we know that they were or either referred by the post-abortion care to the family planning unit or maternity or whatever where the emergency treatment was provided, and they need a system to track them in order to know exactly what happened. So that's what I want to add.
Exactly.
Yeah.
So here again, this may come up in the assessment step of the process, and based on what emerges as contributing factors to the referral system not working, might give information about what strategies or what activities need to take place in order to strengthen the referral system so that folks don't get lost to follow up.
Okay, and I think I just wanted to add in one comment that came in through the question box just about, I think, addressing the question earlier about working groups. And so in Nigeria, apparently there's been a national technical working group, the Post-Abortion Care Network, that's been supported by IPASS, that's done a lot of things, including advocacy.
Mm-hmm.
Mhm.
That's great. And actually, where there are examples of how those working groups perform, how they are formed, how they perform, would be wonderful to share with other colleagues in the countries, because it can help them bypass some of the false starts in trying to form those working groups. So any information that is available about how the working groups are formed and supported and the outcomes and outputs from those groups would be great to share across our partners everywhere.
Okay. Any other question, Chris?
Nope, that's all of them.
Okay, great.
So can we stop here now? It's okay?
All right, I thank everyone for participating, for engaging and staying for the duration of this event, and I look forward to ongoing stories and examples of post-abortion family planning and strengthening its functionality. Thank you.
Thank you, Betty. Thank you so much. Thank you to everybody for joining us this morning. And as a reminder, if you have colleagues who were not able to make it, this webinar was recorded and will be available on the PAC Consortium website by the end of this week. So once again, thank you so much, and have a nice day.